know which ones supply what joint lah. Okay. So sternoclavicular joint dislocation, you can have sternoclavicular joint dislocation, although this is very rare and it requires quite significant force lah, okay? But if it does happen, you can get anterior dislocation or posterior dislocation. But sometimes it is slightly more common in younger people. Remember we talked about epiphyseal plate, okay? When bones in children, they are not fused properly yet, and they have this epiphyseal plate where bones can still grow longer, right? Okay, so at this plate, because it is not fully bone material, fracture can happen at this epiphyseal plate and cause dislocation of the joint. Okay, but again, sternoclavicular joint dislocation is relatively quite rare, uncommon. Okay, so the next joint in the shoulder girdle is your acromioclavicular joint. It is a plain synovial joint. So again, it has a capsule. Articulation, as the name suggests, is between the acromial process of the scapula and the clavicle. Okay, so you have ligaments supporting this as well. You have your superior and inferior acromioclavicular ligaments, and you have your coracoclavicular ligament. Okay, so we'll see the picture here. Okay, so this is your coracoclavicular ligament. It is actually consists of two small ligaments called the trapezoid and conoid ligament. So when you look at the bones later, you will see that on your clavicle, you have trapezoid and conoid tubercles for the attachment of this ligament. You can see tubercle at the bone. Okay, and another ligament is your acromioclavicular ligament here. You can see that these three ligaments support this and makes the joint more stable. Okay. So movement wise, not much movement happens actually here. Just a gliding movement when the scapula rotates or when the clavicle is elevated or depressed. Okay, again, nerve supply, blood supply, I will not talk about it because you don't need to remember at this stage. Okay, all the others, the most important bits are where you can find the joint, so the articulation, and you also need to know the movements that can happen and ligaments that support the joint. Okay. So next in the shoulder girdle is your acromioclavicular, acromioclavicular joint dislocation can happen. Okay, when the joint is separated lah. Okay, but again, this is quite uncommon or rare. Okay, because it's a very small joint and it's quite protected here in the shoulder area. But if it does happen, it can tear or injure the ligament that supports the joint. Okay, and usually they will need a ligament reconstruction surgery. So you can see here an example of say usually in like road traffic accidents or like really big fights, they can get this joint separation or ligament tear as well. Okay, so you can see here and when the patient comes in to the emergency department, sometimes you can see this clavicle, this part of the clavicle coming out of the skin from the front, because it is already separated from the acromion process. So this can sometimes protrude. Okay, but again, this is quite uncommon to happen unless it is a very big traffic accident and they injure this part of the shoulder . Okay, so next, the last joint in the shoulder girdle is your glenohumeral joint or shoulder joint. Okay, so this is a ball and socket synovial joint. Okay, remember ball and socket. So the ball is the rounded head of the humerus. Okay, and the socket would be the shallow glenoid cavity of the scapula. Okay, it is relatively weaker on the inferior side because superiorly it is strengthened by the rotator cuff muscles attachment. Okay, we will see the picture in a bit. Okay, so ligaments of the glenohumeral joint. So we have glenohumeral, coracohumeral, and we have transverse humeral and coracoacromial. So we will see all in the picture here. Okay, so this is the glenohumeral, or also called the capsular ligaments. Okay, is the biggest ligament that supports this shoulder joint or glenohumeral joint. And then we have the coracohumeral between the coracoid process and also the humerus. Then we have the transverse ligament here, and also coracoacromial between the coracoid process and acromion process of the scapula. Okay, so 1, 2, 3, and 4. 4 ligaments support the shoulder joint or glenohumeral joint. Okay, and here also you can see the ligaments lah. Okay, you have coracohumeral, glenohumeral, and coracoacromial. But it doesn't show the transverse ligament lah, which is supposed to be here. Okay. So what other factors stabilizes the joint? Okay, why are there more? Why does this joint need more factors to support it? Because of the weak. It is considered a weak joint because of the thin and lax joint capsule. But this is important because it has greater mobility. Yeah? When it has a more lax joint capsule, you can move at a greater it's more mobile lah. Okay, you need your shoulder joint to be more mobile to create the different movements, right? Okay, so because of this, it is considered a less stable or weak joint. Okay, but it allows the mobility. So it needs some other factors to stabilize the shoulder joint. For example, it has the rotator cuff muscles. Okay, the tendons cross through or cross over the joint to help stabilize the joint in place. Okay, and it has a glenoid labrum, which I will show you in a bit. Okay, and ligaments, as we mentioned earlier, also support or stabilize the joint. Okay, so here you can see this is the glenoid cavity, and you can see this line here, which is the glenoid labrum. So basically, the glenoid labrum helps to make the glenoid cavity more concave, okay, more deep. Okay, so it kind of wraps around the head of humerus when it joins together as a joint. Okay, so the glenoid labrum helps to stabilize the joint, make it more attached lah. Okay, and then you have the rotator cuff muscles here. So from anterior view here, anteriorly, you can see there is this subscapularis muscle. Okay, the attachment of the subscapularis muscle is on the humerus, so it crosses over the glenohumeral joint. Okay, and at the back you have the other 3 rotator cuff muscles, which are supraspinatus, teres minor, and also and also infraspinatus muscle. Okay, so these 3 muscles also cross over the glenohumeral joint and helps to stabilize the joint. Okay, you can see the crossing over here and here. Okay, so again, blood supply and nerve supply, you can have a read on your own, but we will not ask you in the exams. Okay, dislocation of shoulder joint, you can get the head of the humerus can sometimes be dislocated out of the glenoid tubercle. Okay, and you can get anterior dislocation as well. Well, in dislocation of the shoulder joint, the most important thing is you have to be careful that the axillary nerve is not injured. Okay, because sometimes when there is injury of the dislocation of the shoulder joint, if because the axillary nerve is quite close, it runs quite close to the shoulder joint. Okay, it can sometimes be damaged if there is any shoulder joint dislocation or glenohumeral joint dislocation. Okay, so what happens if there is damage to the axillary nerve? The patient gets paralysis of the deltoid and loss of sensation over the regimental badge area. Okay, so for example, if the patient comes in after a big traffic accident, for example, and they complain and that they cannot feel anything over the regimental badge area, or when you do the test that they cannot sense and have any feeling there. So you might think about axillary nerve injury. Okay, so just to show you, this is the regimental badge area here lah. Okay, regimental means, you know, in the army or brigades, they have this badges that they wear. Okay, so that's why they call this area the regimental badge, because that's where apparently that's where they wear the badge lah. Okay, and here another injury that can happen around this area is the rotator cuff tendinitis. Okay, so because rotator cuff muscles are important in stabilizing the glenohumeral joint, so when you move the joint a lot, sometimes it can put strain or it can inflame the muscles here as well. Okay, so which are the rotator cuff muscles. So how would you know that someone has rotator cuff tendinitis? Okay, usually patients will come in saying that they have pain in their shoulder, but it's very not specific. But when you ask the patient to abduct their hand or lift their hand up at between 60 to 120 degrees is where they will feel the pain. Okay, the pain is due to the supraspinatus muscle being in contact with acromion during the 60 to 120 degrees abduction lah. So this is just a picture showing you. Okay, you ask the patient to lift their hand from here to here, from 0 to 60 degrees. They will say there's no pain, but once they lift at 60 to 120 degrees, they will say it's painful, doctor. Then after 120, they say, oh, there's no more pain. Again, okay, the pain disappeared. So you know, if there is pain between 60 to 120 degrees, that is the patient has rotator cuff tendinitis or painful the inflamed rotator cuff muscles lah. Okay, and this is called painful arc, the pain between 60 to 120 degrees, and this pain is due to the contact of the inflamed supraspinatus muscle being in contact with the acromion process of the scapula. Okay, so just remember the painful arc lah. Okay, between the 60 to 120 degrees. Okay, so that's all about the shoulder girdle. Okay, so all there's 3 joints in the shoulder joint and shoulder girdle, which are your glenohumeral. Okay, and okay, but I'll just recap. Show you again. Okay, so you have glenohumeral here, acromioclavicular, and sternoclavicular. So remember 3 joints in your shoulder girdle. Okay, so next we will talk about the elbow joint. Moving further down from your arm towards your forearm is your elbow joint. Okay, so the elbow joint connects your arm to your forearm. Okay, from if you have a feel of your own elbow joint, you can feel actually 3 structures. So on the medial side, you can feel your medial epicondyle. On your lateral side, you will feel your lateral epicondyle, and in the middle, you will feel the olecranon process of the joint. So if you see here, if you have a feel of your elbow joint, you can feel this medial and lateral epicondyle. Okay. And if you flex your elbow, you can also feel this part here, which is your olecranon process. Okay, so from the outside, these 3 structures is where you can find is marked the elbow joint lah. Okay, it is again a synovial joint and functionally as a hinged joint. Okay, so it consists of 2 separate articulations. One is between the humerus and the ulna, and one is between the humerus and the radius. Okay, so if you see here, so this is the humerus. So the elbow joint connects the humerus and the ulna, and also the humerus and the radius. Okay, so there's 2 articulations per se lah. Okay, again here you can see humerus, radius, and ulna. So this is where you can find the elbow joint. So like all the other joints, it has a capsule surrounding it. Okay, and it is also strengthened by ligaments. You can see here you have the ulnar collateral ligament, the annular ligament. Here you have radial and ulnar collateral ligaments or lateral collateral ligaments, and also the annular ligament supporting the elbow joint. Okay, and because the most importantly in the elbow joint, you also have bursa. Remember bursa? What bursa are? Basically, it's just a sac filled with fluid. Okay, it acts as a cushion to prevent any degenerative changes lah. Okay, because a lot of movement happens at the elbow joint, so it needs some cushion to reduce the friction and prevent degeneration lah. Okay, so the three main important bursa is intratendinous, subtendinous, and subcutaneous or olecranon bursa. So this, you can see the subtendinous. Subtendinous just means it's in front of the tendon. Intratendinous, it's inside the tendon. Okay, and olecranon is just behind the olecranon process here. Okay, if you imagine the olecranon, you always put your elbow on the on your table, right, when you study or when you're bored and things like that. Okay, so the bursa can actually be become degenerated if you always use that, you always do that to your elbow. Okay, so the cushion can sometimes become degenerated and inflamed. Okay, so just to show you again, so the ligaments here, you have your ulnar collateral ligament and radial collateral ligament. Okay, so this helps to stabilize the elbow joint. Neurovascular, you won't need to know for now. Okay, you will learn about the cubital fossa and the contents. So movements, as it is a hinge joint, it allows only for extension and flexion of the forearm. Okay, and the muscles and all, I think you've learned with Dr. Reshma, so I won't ask about muscles and in the joints of upper limb questions lah. Okay, because all those will be covered by Dr. Reshma's questions. Okay, so clinically, the bursitis can be inflamed also, as I mentioned earlier. Repeated friction or use of pressure on the bursa can cause it to become inflamed. So specifically, if it's subcutaneous, sometimes if there is too much pressure on this area, it can become inflamed, or sometimes if you get a cut in the area, it can become infected and inflamed as well. Subtendinous bursa, you can get if there is repeated flexion and extension. Usually in factory workers or assembly line workers, they flex and extend the hand a lot when they are working in the factory. Okay, so they come complaining of painful flexion of the forearm. Okay, they say, doctor, it's a bit painful when I do my work and flex my arm. So you can kind of diagnose it could be subtendinous bursitis due to the repeated flexion and use of the forearm. Okay. Dislocation, sometimes you can get also elbow dislocation. Okay, mostly they are posterior, and you name the dislocations according to the position of the ulnar and radius and not the humerus. Okay, so for example here, this is called posterior dislocation because the humor, we don't use the position of the humerus, rather the ulnar and radius to name the dislocation posterior or anterior. Okay, so here you can see the posterior dislocation, anterior dislocation in relation to the humerus. This is lateral in relation to the humerus, medial, and divergent is other than posterior, anterior, lateral, and medial. Okay, so this is just an X-ray showing you posterior dislocation. Okay, next in the elbow, you can also get epicondylitis or tennis elbow or golfer's elbow. it is named as such because tennis elbow, those who play tennis a lot often gets tennis elbow, and those who play golf a lot gets golfer's elbow. Okay, because in tennis players, they get lateral epicondyle pain or epicondylitis because they use backhand. You know, if you play tennis, there's the way you bat. One of the movements is called backhand movement. Okay, and that kind of you kind of use your extensor muscles a lot during playing tennis when you use that backhand posture lah. Okay, and golfers, they use their flexors to hit the ball, right? So they use a lot of flexion rather than extension. Okay, and because of the origin of the muscles of the from the lateral epicondyle is mainly for extension, so that's why the tennis player gets lateral epicondylitis, whereas the muscles that produce flexion often comes from the medial epicondyle, so that's why the golfers get medial epicondylitis. Okay, so if I just show you here, okay, so this is your lateral epicondyle. Okay, and all your extensor muscles mostly come from the lateral epicondyle. So if you use your extensor muscles a lot, especially in tennis, for example, in tennis, you can, even if you're not a tennis player, but if you use a lot of extension for a long time and rigorously, you can get lateral epicondylitis or tennis elbow. Okay, because the usage of this muscle can sometimes cause too much pressure on the extensor origin of these muscles. Okay, and similarly in medial epicondylitis, because all these flexor muscles come from the same origin, which is the medial epicondyle. Okay, so in golfers who do too much flexion during golfing, they can sometimes get golfer's elbow or pain here because of the inflammation of the epicondylitis. Okay. So another injury that can happen near the elbow area is supracondylar fracture. Okay, and this is basically a transverse fracture that spans between the two epicondyles. Okay, so this is the humerus. Okay, and this is the supracondylar fracture span between the two condyles, the medial epicondyle and lateral epicondyle. So between the two condyles, you can get supracondylar fracture. Okay, and why is this important? Because it can sometimes injure the brachial artery which passes nearby. Okay, so if you can see here, this is the brachial artery here. It passes nearby the supracondylar area. If there is dislocation of the supracondylar fracture, it can cause injury to the brachial artery, and this part of your arm or forearm would be void of blood supply to the areas or muscles here lah. Okay, so the next joint. Okay, so we've talked about the elbow joint. Now we move on to the radio-ulnar joint, which is divided into proximal and distal radio-ulnar joint. Okay, just to show you here, so this radio-ulnar joint means it's between the radius and ulnar, right? Okay, so proximal means closer to the body, and distal means moving further away. Okay, so this is the proximal radio-ulnar joint, and this is distal radio-ulnar joint. Okay, so proximal ulnar joint, it is held in place by annular radial ligament. Okay, and it produces the movement pronation and supination. So you can see here, this is the annular ligament that holds the head of radius and supports the proximal radio-ulnar joint. The distal radio-ulnar joint, it has anterior and posterior ligaments, and also it has an articular disc which helps to bind the radius ulnar and the wrist joint together. Okay, so this is what is shown here. So radius, ulnar, and also the wrist joint. So there is an articular disc that helps to hold them together. Okay, again here the movement is pronation and supination. So do you know pronation and supination like this? So you can flip your hand upwards and backwards. So that's pronation and supination. You can kind of twist your forearm. Okay. So you also have interosseous membrane, which is like a sheet of connective tissue that helps to hold the radio-ulnar joints together. Okay. So this is the interosseous membrane. It spans between the radius and the ulna and holds the two bones together. Okay. So you can get fractures at the radius and ulna as well. Okay, so you can get Monteggia and Galeazzi's fracture. I think when you do orthopedic posting, you will go through this, or surgeons will ask you about this fracture. So just remember for your future. Just remember Monteggia and Galeazzi's fracture. Okay, so I have a very nice picture for you to help you remember. Okay, so the word mugger, MU, means Monteggia's fracture in ulna. Okay, and Galeazzi, GER, so Galeazzi fracture in radius. Okay, and because A is proximal compared to Z, so A is ulnar fracture in the proximal bone or proximal area. Okay, and Z is more distal, so it is Galeazzi is radius fracture in a more distal area of the bone. Okay, remember this is proximal and this is distal. Closer to the hand is distal, closer to the arm is proximal. So you just remember the word mugger, MU. Monteggia is ulnar fracture and it is more proximal. GER, GR is Galeazzi fracture is radius fracture and it is more distal because it has a Z. Okay. Okay. 2 seconds. I have to take my baby.
All right.
Okay, so next is joints of the wrist. Basically, at the joints of the hand, you have the wrist and the carpal joints. Okay. Okay, so the wrist joint is formed by the proximal row of the carpal bones, except the pisiform, and also the distal end of the radius and the articular disc that we saw earlier. Okay, the ulna per se is not part of the wrist joint, rather that the articulation disc that at the end of the ulna. Okay, so you can see here, this is the articular disc. Okay, and this is the radius, and these are your carpal bones that make up the wrist joint. Okay, ligaments, you have the palmar radiocarpal, dorsal radiocarpal, and ulnar and radial collateral ligaments. Okay, you can see in this picture here, ulnar collateral, radial collateral, palmar radiocarpal is on your palm side of the hand, and at the back of your hand you will have your dorsal radiocarpal ligament. Okay, as the name suggests, radiocarpal means it is between your radius and your carpal bones. Okay. Neurovascular supply, I won't mention. Okay. Movement wise, you can try with your own hand. It has an ellipsoid type of synovial joint. Okay, you can do flexion, extension, adduction, and abduction at the wrist joint. Okay. And muscles will only be taught in Dr. Reshma's lecture. I think she has gone through with you, right? All these muscles. and I will not ask you in my part of the questions, but rather she will ask you the functions of the muscles lah. Okay. So injuries to the wrist joint, you can get fracture of the scaphoid, okay, which is one of the carpal bones. Usually it is falling on an outstretched hand when the wrist is flexed. Okay, you can get fracture of the scaphoid. Okay, and when a patient does get fracture of the scaphoid, they get pain in this area called the anatomical snuff box. Okay, so this is the scaphoid. Okay, I'll just talk a bit on the anatomical snuff box. Has Dr. Reshma taught you the anatomical snuff box? Sorry?
She mentioned it, but I do not understand what it is.
Oh, okay. So basically, it's just an area in the wrist area, okay, which is a triangular shape. Okay. So the lateral border is formed by the tendons of the abductor pollicis longus and extensor pollicis brevis. Okay, so you can see here, extensor pollicis brevis tendon and abductor pollicis longus. These two tendons here, this forms the lateral border of the triangle or anatomical snuff box. Okay, and the middle border is formed by this tendon of the extensor pollicis longus here. Okay, so lateral border and middle border, and the floor inside here is formed by the scaphoid, trapezium, and distal ends of the tendons of extensors here lah. Okay, so basically the most important thing you need to know about the anatomical snuff box is that the radial artery is inside it or runs inside the anatomical snuff box. Okay, so injury to this area can actually cause injury to the radial artery. Okay, so but in this case, because the scaphoid is actually inside or in the floor of the anatomical snuff box, so if you get fracture of the scaphoid, this is where you can, the patient complains of injury. So for example, if a patient says they just had a fall and they on an outstretched hand, so they stretched the hand and fell or fell on and stretched the hand, right? Okay, so and then they say, oh, there's pain here, which is here in the anatomical snuff box, and you can see some swelling there as well, and when you touch it, it feels tender, so you might want to suspect a scaphoid fracture. So you ask for an x-ray, and sometimes you will find the scaphoid is fractured in this case lah. Okay, so also at the wrist you can get anterior dislocation of the lunate. The lunate is also one of the carpal bones. Okay, so this, because it is very close to the carpal tunnel area, so you can get symptoms which are the carpal tunnel syndrome. Okay, so if I show you here, so this is the carpal tunnel area here underneath your flexor retinaculum. Okay, so what are the common causes? This includes the dislocation of lunate. Okay, as you can see here, these are your carpal bones and this is your lunate here right in the middle. So it's very close to this flexor retinaculum here. So if it is dislocated, it can compress the median nerve. You can see here the yellow line here, which is kind of here. So that is where your median nerve is. Okay, so dislocation of the lunate can easily compress the median nerve, and the syndrome is called carpal tunnel syndrome. Okay, so because the median nerve innervates all these muscles here, okay, so that's why they get the carpal tunnel syndrome, which is pain and numbness and tingling in the thumb, index fingers, middle finger, and the thumb side of the ring fingers, and also weakness of the thenar muscles. As you know, the median nerve supplies the thenar muscles. Okay, so I think that's all for my lecture on the joints of the upper limb. Do you want questions now, or you can email or WhatsApp me the questions? Okay, is that okay?
Yeah, I think okay. Doctor. So should I send the attendance link?
Oh yeah. Yesterday I forgot. Yeah, can you send the attendance link now?
All right, Doctor.
Okay, thank you. Okay, thank you everyone.
Thank you, Doctor.
Thank you, Doctor.
Take it, Doctor.